Happy New Year. Welcome to the first in our 2015 webinar series. This is a monthly series of events designed to explore and share our network's research into psychological and social aspects of bipolar disorder. So a couple of notes quickly on the webinar process before we start. The webinar is being recorded. It will be posted online after the event. However, the attendee list, i.e. your names, won't be recorded and will be published. Due to the fair number of participants on the line today, we will have muted your telephone lines and audio lines if you're using your computer for the duration of the actual presentation. The presentation itself is going to run for about half an hour, about 30 minutes, which is going to leave us ample time for questions when we come to that point. If you look down to the bottom right-hand side of your screen there, you can see a chat box and a question box, and you can type your questions right in there and we'll field them when we come to that stage. Okay, so on to the actual recording. It's my real pleasure to introduce our speaker today, who's going to be talking on recovery-focused cognitive behavior therapy for bipolar disorder. This is Dr. Steven Jones from Lancaster in the UK. Steven is a long-standing CREST.BD member. More importantly, he is also the founder and co-director of the Spectrum Center for Mental Health researcher at Lancaster University, which is up in the north of England. Lancaster and Spectrum in particular really are at the forefront of some of the work that's happening internationally on new ways for engaging people who live with bipolar disorder and clinicians in research. And I would say that they're producing some of the best work internationally on psychosocial treatments for bipolar disorder. So it's a real pleasure to be able to have Steven with us today talking about some of their recent results. Steven himself received his PhD and his clinical training at the Institute of Psychiatry in London, where he had an academic post before moving to the northwest of the UK. And there he worked in the National Health Service as well as at the University of Manchester until 2008, at which point he became the founding director of the Spectrum Center for Mental Health Research. So it's my point to hand over the baton to Steven Jones and to move on to the main part of the webinar.
Great. Well, thanks, Erin. I presume everyone can hear me. This is my first go at a webinar, so bear with me. So thanks for that. It's great to be given the opportunity to talk further about recovery-focused approaches to bipolar disorder. This was funded by the National Institute of Health Research in the UK as part of a programme grant. And there are a number of people I'd like to thank. I'm just slightly struggling to, I'm just slightly struggling to progress the slides at the moment. Yeah, can't make the slides go forward just right now. There we go. So yeah, there's a number of people involved in this. Obviously, it's not my sole work. A range of people, researchers and clinicians have contributed massively to this, and in particular I'd like to recognise the work of the Service User Reference Group that we had in the recovery programme, who were involved in every stage of the work on recovery. I mean, I guess one question is why we were looking at this and what the motivation was for this focus. I think in terms of the sort of main focus of interventions in respect to bipolar disorder, particularly around psychological interventions, they're on symptom reduction and relapse prevention. In the UK, we've had the new NICE guidelines published in 2014, and again, the primary focus is on those two issues, which to an extent is perfectly reasonable. Those are things that people value. But clearly, people's lives encompass lots of other things other than mood variation and relapse. So what about those? And also, relapse itself is by no means a binary outcome, even though in a lot of the research trial studies it's treated as if it were one. So the picture is a bit more complicated than some research would have us believe at face value. I think linked to that is issues around recovery. So on the one hand, there's clinical recovery, which I guess is resolving of symptoms back to a more euthymia state and the avoidance of relapse. But there's also personal recovery. And personal recovery, whilst it can overlap with clinical recovery, is not necessarily nested within it for all people. Certainly in terms of the consumer data, people seem to value personal recovery, and as I say, whilst for some people that is actually highly linked to symptomatic change, for others the link is less clear. And in terms of the UK in particular, the area I'm most familiar with, recovery is very much reflected in government mental health policy, and indeed in the tone and flavour of the NICE guidelines for bipolar disorder. But the therapies themselves don't actually focus on personal recovery outcomes, which leads to an interesting challenge about how do you meet those sort of goals if actually your therapies aren't really directed towards them. And then another sort of linked issue is around the importance or the potential importance of actual early intervention for bipolar disorder. And this relates to a number of issues. Certainly there seems to be evidence that delayed treatment is in general associated with worse outcomes for people with bipolar, both in terms of functional and symptom outcomes. Also, if you look at later episodes, in people with a more established course of bipolar disorder, there seems to be a tendency that life events that trigger those are more minor and often ones previously linked to mood changes, so that almost a pattern has been developed over time. And that actually those links less often are mediated by cognitive processes. Now the implication of that is that psychological interventions might therefore actually be rather more powerful when applied earlier in the illness course. Other research that links in some way to this is that certainly the Scott trial, which was a large MRC study on CBT for bipolar disorder in the UK, found evidence that CBT may benefit more those with fewer episodes. And we also know that people with an earlier onset are an important group because actually they tend to have worse clinical outcomes overall as well. But alongside that, there's the challenge that it does seem to take a long time to have bipolar disorder actually identified. So a recent survey of 700 people with bipolar run by Bipolar UK, which is the lead voluntary sector organisation for people with bipolar across Britain, and in partnership with Bipolar Scotland and the Royal College of Psychiatrists, identified that people still, it takes over a decade for bipolar to be diagnosed. It's often wrongly diagnosed, and many people felt that their condition had been made worse by inappropriate treatment. So it seems important to both identify bipolar at the right time, and also to at that time be offering people interventions that are appropriate and meaningful to them. So out of that sort of context, we were interested in Recovery Focus CBT, and the intention with this was to provide a flexible but structured intervention. So something that benefits from the current evidence base, but it also matches the intervention to the priorities that each client has, and targets individuals early in the illness course, or early in the course of their bipolar disorder, to hopefully improve outcomes at the time, but also with the potential to improve trajectory in the long term. And also to focus on a particular outcome which certainly research in the UK and beyond, and our own service user consultation has indicated is highly valued, and that is personal recovery. The development of this goes back many years. So we did a pilot case series which was published in 2008 on a version of this intervention, and that looked promising, but it highlighted a range of things which we tried to incorporate in the actual trial around flexible engagement, giving time to consider the meaning of the diagnosis, doing a systematic review with each client of their coping skills, and looking at the role of how appraisals of fluctuation in affect or mood, so how people actually make sense of how their mood changes and how that influences what they subsequently do in response to that. So that influenced the development of the therapy manual for the actual trial, but we also conducted in-depth qualitative interviews with people with lived experience of bipolar disorder about what their personal experiences of recovery were. And we also conducted focus groups, again with groups of people with bipolar, to get a sense of what sort of content format and what sort of supporting materials people might want in an intervention that might address recovery-related issues. So as a result of the qualitative work, we got a bit of a sense of what people identify as elements within recovery, because obviously it would make no sense at all to take a recovery approach and then assume we knew as academics and clinicians what that might mean for people. So what people were saying was that there's sort of 4 key areas that were important. So the first of these was having mood experiences that were understandable and manageable. So that was people having a frame within which to understand what was going on, and that isn't necessarily a psychosocial or psychosocial vulnerability model in particular. It's a model that has a coherence to that person. Also, there's an element of developing resources to self-manage health, within which people were talking about an awareness that support and care from others was often highly valued when people were acutely ill, but the transition to being much more a manager of one's own care in the longer term was something that people both highly valued and also identified that at times that process could be clunky, so that the desire to have more autonomy wasn't necessarily reflected in what people were offered. Another domain was access to personally meaningful recovery. So that was, again, varied. So for some people that was about going back to and engaging with activities people had been involved in before they'd become unwell. But also for some people, and I think this links to elements of Erin's work, some people were also saying that actually it was about moving forward into new ranges of activities that they hadn't previously engaged in. And I think the final thing was seeing recovery, or personal recovery in particular, not primarily as a single point that they aimed for, but actually as a lifelong process. And what people were saying was that by accepting fluctuations in that people were more able to sort of see recovery in context rather than feeling that any changes in it could be potentially demotivating or feel rather catastrophic. In terms of the focus group data, some of the things that people were highlighting that are relevant to the intervention were focusing on hope and opportunity in relation to the intervention, having a flexible intervention, both in terms of where it was delivered and how long sessions were and how frequent they were, having good quality supporting materials, including recovery stories from other people, having, as a result of the intervention, a personalised and documented recovery plan, and the client having control over sharing of that sort of plan and other things with the wider mental health team, and measurement of functional outcomes as well as symptoms. And I think we tried to incorporate all of those elements in the intervention itself. In terms of the intervention, that was delivered by mental health professionals who are trained in cognitive therapy approaches, and they also received training obviously in this specific intervention. People could receive up to 18 hours of therapy over a 6-month period, and the frequency of the sessions broadly varied between once a week and once a fortnight over that time. There are a number of ways in which the intervention differs from standard CBT for bipolar. There's an explicit focus on client-focused goals rather than a presumed target of relapse prevention. It's a formulation-driven approach rather than applying a very similar model of bipolar experience across a diverse range of clients. There's the freedom to work within whatever model the client brings, and an openness to addressing, appropriately enough, functioning and comorbidity issues as well as mood problems. But I guess obviously one challenge here is how you identify recovery goals. So that can obviously be done by structured interviews with clients, but the reality is in practice many clinicians won't have time to do that as well as everything else with people. So As a precursor to the actual trial itself, we developed a quantitative measure of recovery, which is the Bipolar Recovery Questionnaire, which is intended to be able to both indicate patterns of recovery goals and also give a sense of whether the particular intervention is improving people's recovery outcomes from when treatment was started. So there's a couple of ways in which this measure can be used. That's actually a paper published in the Journal of Affective Disorders the year before last now, actually. So that's something that I'm sure we can circulate if people don't have access to that and would like to. In response to the focus group suggestions about resources, we developed a resource pack for people which is called Tools and Choices and had a range of sections in them. So some of this was basic therapy information and appointment details. There's also useful information in terms of contacts that were relevant to the people, websites, support groups, and also service user poetry. Section 3 had the recovery stories that people were asking for. Then Section 4 contained information that was worked on and developed by the client and their therapist during therapy and then added to the pack as they went along. Similarly, Section 5 then had early warning signs and coping information on sleep and stability, and also the recovery plan. And then Section 6 was future thoughts and ideas, and that was an idiosyncratic section with anything that people thought might be relevant to their own recovery story. And we tried to do those as in line with what people were suggesting in reasonable quality, and we were fortunate to have art that we were able to use to brighten up those materials, which was created by Debbie Mays, who was one of our service user researchers at the time. So the interventions intended to enhance personal recovery, and we wanted to look at the impact that this also had on reducing relapse. We wanted to have a reasonably early intervention, so this was people with less than 5 years since the onset of their bipolar disorder, and these were also people who met full criteria for bipolar. We wanted to look at this from a feasibility and acceptability perspective, so we wanted to know that if you offered this type of intervention to people, would people actually take up the offer? And if they did take up the offer, would they continue to attend, or would they have a session or two and then decide it wasn't for them? And in terms of outcomes, our primary clinical outcomes were personal recovery measured by the BRQ and time to relapse of a mood episode using the SCID. We were also looking at quality of life and social functioning, so we used Erin's Qual.BD for that, for the quality of life, and the personal and social performance measure for an overall measure of social functioning. We don't need to spend a lot of time on this. This is just to show you that we screened 125 people and randomized just over half of those into the trial. So 34 people received treatment as usual, and 33 people were allocated to the therapy intervention. And in terms of the kind of feasibility outcomes we were talking about a few minutes ago, 32 out of the people offered the therapy received at least 6 sessions of the intervention, and the average was 14 out of 18 sessions. So it does seem that if you offer this to people, they do seem to be interested in engaging with it. In terms of fidelity to the intervention, so were therapists able to deliver this, we developed a recovery fidelity scale to check this out, and we found that there were good adherence levels, so 91% for therapists, and also that people's mode of therapy was consistent with cognitive therapy good practice as measured by the CTSR, which is the cognitive therapy scale revised. Okay, on to outcomes. So if you look at the bar chart I've got here, we've got the people receiving the intervention are the red bars, the people receiving treatment as usual are the blue, and a higher score on the recovery measure is better. And basically the analysis indicates that there are significantly better outcomes allowing for baseline values at follow-up at both 6 months and 12 months for the people in the Recovery Focus CBT group. So that's encouraging that the intervention designed to enhance personal recovery seems to do so, and seems to, that the gain seems to persist beyond the active intervention period. When we were looking at recurrence, we looked at, first of all, time to any episode, whether it's depression or mania, and this is a survival curve for the treatment as usual group, which are these is the solid line, and the recovery focus CBT group, which is the dotted line. And essentially what that shows, what the line shows, is the slower, the flatter curve for the intervention group indicates it was time to an episode was longer in that group, and also a smaller percentage of people experienced an episode. That pattern is essentially replicated when we look at time to first depression and time to mania. So I think this is potentially quite an interesting outcome because, as I was saying, this is very much an individualized intervention. It wasn't primarily focused on management of relapse, and yet by focusing on personal recovery outcomes, we have actually had quite a powerful effect, it seems, certainly in this relatively small trial, on relapse outcomes as well. In terms of quality of life, this isn't quite meeting or getting below the magic 0.05 significance level, but it's certainly encouraging. It's very much in the right direction that people receiving the intervention score themselves as having better quality of life at both 6 months and 12 months. So I think that's very promising, particularly for a larger and more definitive evaluation of this work. And in terms of personal and social performance, it certainly seems to be broadly in the right direction during the active intervention period, but flattens out at 6 months follow-up. So it's unclear just how meaningful that change is really from a sort of definitive point of view. So to just kind of wrap up on what I've been talking about, it seems at the very least that this kind of new intervention is feasible in terms of we managed to recruit pretty much the target number of people we needed. People stayed in the trial, and we had a decent level of retention to the actual assessment. So we were asking quite a lot of people in terms of, quite a significant intervention and then a substantial follow-up period, and most participants were kind enough to engage with both elements of that. And as I was saying, engagement with therapy and also fidelity around delivery by therapists seems to be promising. As I've indicated, the clinical outcomes are an increased time to relapse for both POLS and mood episode, improved recovery, improved quality of life, and interestingly, for reasons of brevity, I haven't put up the slides on mood outcomes, but and those weren't particularly primary outcomes, but we did find that outcomes for mood were non-significant. So these were people who are out of episodes, so their residual levels of mood symptoms weren't particularly high, but the impact on relapse and recovery and quality of life seemed to be more associated with those things in and of themselves than they were with a particular impact on subsyndromal mood features. So I think our take on it anyway is that this looks like a promising novel therapy. What we want to do next is to move on to a more definitive trial so that we could evaluate this in a more national study with a broader range of people, and obviously at a larger scale to obtain more definitive and precise estimates of the effects that we think we're seeing in this pilot study. And I think the other crucial thing that we want to do is have a formal assessment of the costs and benefits of this therapy, because obviously the reality is, certainly in the UK and I'm sure in Canada and elsewhere, that the likelihood of these things going into actual clinical practice is significantly influenced by the economics of the intervention. Having said that, the impact that this seems to have, particularly on mania relapses, suggests that it's quite likely to fare reasonably well in a cost-benefit analysis if we were to do a large-scale study. Right, well, thank you very much for your attention. This is my email address. If you want to contact me to know more, I'll hand back to Erin.
Thank you for that wonderful presentation, Steven. It's wonderful, first of all, to see this data come out. I know how much hard work went in from so many people into that trial, so it's wonderful that you're at that stage. It's also amazing as well, though, to see the recovery paradigm being fully embedded in the landscape of psychosocial intervention research in bipolar disorders. So it's just, I think, a really step forward in terms of that particular field that you've made. So kudos to you. So a couple of points of clarification that have come through while we've been on the line. One person on the line was asking if you could define what SCID means, and then the secondary. That's okay. And the secondary part of that, if you could also talk a little bit more about your sample for us. Was it bipolar type 1 and type 2, and what did that look like?
Okay, yeah. So SCID is the structured clinical interview for diagnosis, and is a so there's the diagnostic interview, which is used to determine whether people have a pattern of symptoms which is consistent with bipolar disorder, and then there's SCID Life, which is the longitudinal interview follow-up evaluation. I think is the unpacking the whole acronym. But basically the gist of that is that's an interview in which people are asked structured questions about how their mood's been over the period since the last assessment they've had, and gives the team an indication of what points within that period, if any, people have entered into an episode of either mania or depression or a mixed episode. I think there was another question about the sample. People were predominantly bipolar 1. People were, I'm just trying to remember their age, they were, I think we worked out they were about 8 to 10 years younger than the average sample so they were in their mid to late 30s, so 8 to 10 years younger than the average sample in most of the standard CBT, RCT, randomized control trials that have been published previously, and that would be kind of consistent with the early intervention focus. They're both men and women. There was substance use. There wasn't a phenomenal amount of substance use, but some people were using substances. And as with most of our studies, although some people were working, the majority of people were unemployed or working in, not working full time, I should say, actually, would be more accurate.
Thanks for that. And as a follow-up question, so it seems like the majority of people experience an onset of bipolar disorder between sort of 18 to 22, 23 years. What would be your thoughts on adapting or using this intervention in that age range? Thinking in particular about some of the recovery principles and themes that are embedded in it, things like, looking at the person's sense of self and identity and, the meaning that they draw from particular aspects of their life. And, it makes me wonder about whether this might be an intervention that's particularly suited for people who have just been diagnosed with bipolar disorder.
Yeah, I think one of our plans is to do, if you like, the larger version of this, very much based within early intervention teams within the National Health Service. And the advantage of that is that early intervention teams do pick people up at late adolescence into early adulthood generally. So that we would have more opportunity to pick those people up. And there are a number of services that are also offering some support to people who are not quite meeting diagnostic criteria but are having difficulties. So I think there would be opportunities for that sort of moving this. So this is a bit earlier than the significantly earlier than some of the previous interventions, but I think the challenge to move it earlier still would be something we would embrace. And I think the flexibility within it also lends itself to doing that, because I think you have a structure within which to address what people are bringing. I should say though, I mean, obviously I'm sure people are aware there is another peak which is kind of in the mid-50s onwards for people in terms of onset, and we've got one of our researchers here has just is just starting a fellowship to develop this intervention also for older adults. So we're trying to look at both ends of the spectrum in tune with our name.
Thanks for that. So another question here, which is around your thoughts on the efficacy broadly of CBT for mania.
I think in terms of the evidence base, I think there are a number of studies that suggest that CBT is helpful for addressing relapse to mania, although there are some mixed findings. In terms of CBT actually being delivered, to people who are currently experiencing significantly elevated mood, I think that's a really interesting question that hasn't been addressed in the literature yet. The majority of people, well, the vast majority of the studies, in fact I think pretty much all of them, engage people when they're in between episodes. Now obviously when you've got a 6-month study, that doesn't mean that no one ever goes into an episode during that period. And I mean, my sense, so I'm kind of moving away from trial data to clinical experience here, just to give people a sort of warning flag. But my experience is that when you have somebody engaged within CBT and their mood begins to elevate, it feels as though there is quite a lot you can do if you've done the groundwork with engaging people in the intervention. And I think that's a very different thing from trying to engage somebody once their mood has got to that point, which I think is a much more difficult thing to do, and something in which there would be a lot more resistance, I would anticipate, to engaging with the sort of strategies that people actually might be more willing to engage with, if the groundwork is done in advance.
So it sounds like you're saying in part that, if you can cover the principles of the approach inherent in CBT during periods when people are well, then it might put them in a better position to enact them during periods of hypomania to stop full progression into a full manic episode.
I mean, yes, I think so. I mean, it's something we need to look at more formally, but certainly in my clinical practice, I've had people who, I've seen for a period of time who've then, some while later got back in touch because, they've been aware that something's been happening. And, they're quite often, I can think of a number of cases where people have been really quite elevated, but actually it was still possible to, work with them, in a sense, with their own words about what they previously found they needed to do in that situation, and they could, would be able to actually still do that, even though, they were in, quite an elevated mood state. So I think that does enhance the potential of it, yes.
Clinically, have you ever worked using CBT approaches with somebody who's experiencing psychotic type symptoms around, testing assumptions and, using the core principles of CBT to try and chip away at psychotic type experiences?
Yes. In fact, before I did the bipolar, started focusing on bipolar, a lot of my clinical and research work was in psychosis, and so I've had quite a lot of involvement in that approach. And actually, when we're working, doing training workshops for clinicians here, we do talk quite a lot about some common themes that people can draw on in their own experience. So I think clearly there's a combination of things maybe with bipolar. So there's current patterns of psychotic symptoms somebody may be experiencing, and there's also that sort of sense of having experienced sort of psychotic symptoms, and although the frank symptoms may have gone, there's kind of the making sense of what had happened and the questions around that are still there. And yes, I think all those sort of the CBT for psychosis principles in somebody who's experiencing those issues can readily be incorporated into work with somebody with those sorts of difficulties, yeah.
It's interesting. It sounds like another ripe area for a qualitative study as well, where we talk to people about their experiences of the interplay potentially between CBT approaches and psychotic experiences.
Yes, I mean, I was just thinking one of the things we've been doing, as you'll know, was working on the area of anxiety in bipolar disorder, and I mean that's an area where there does seem to be, for some people, this is not the case, but for some people there is a kind of convergence, as you might expect, between kind of residual psychotic experiences of paranoia and that sort of thing and anxiety. And clinically anyway, you know, using some anxiety-focused approaches seemed actually quite beneficial for some people. And I was looking at some research Dan Freeman's doing in Oxford on paranoia at the moment. He's which looks very interesting. It seems to sort of be in tune with that sort of theme, because they're looking at addressing worry in people with paranoia and the impact that has actually on their psychotic experiences. And they've got some pilot data that shows that targeting that area of worry and anxiety is also quite a potent tool in addressing, you know, some of these psychotic-related phenomena.
Some questions coming in about the bipolar recovery questionnaire.
Okay.
So you mentioned that it's in the public domain, and people are wondering, you know, how you would embed that, how you could you embed it into, you know, your daily life? How would you interpret the results if you were to do it, you know, by yourself without the support of a clinician? And then maybe you can actually describe for us what it would look like, you know, using the information from that potentially to formulate recovery goals around that, and describe in a little bit more detail what that process would look like.
Okay, well that's a nice easy one, thank you. I think that's a good question. I think that on the whole, I would generally feel that it's probably most helpful to do this in discussion with somebody else, because I think that just because that other perspective is often a helpful thing to have in lots of sort of reasonably complicated situations. I mean, the bipolar recovery questionnaire itself is, there are 33 items, and they cover the sorts of themes that I was highlighting that we picked up in the qualitative work. And for each question, we're basically asking the person what's their perception of how they're doing in relation to that area. So we're not trying to quantify, you know, how many times do you go to the shops, or how many job applications have you put in, or, you know, are you having, you know, how's your, you know, define your interaction with your children or whatever. It's much more about people's perceptions of those areas. So the point of having a large and, you know, reasonable number of items was that that then gives people the opportunity to have a bit of a profile. And I mean, there's no reason particularly that people couldn't have a look at the questionnaire and look at their own profiles. I mean, that's fine. If people want to access the questionnaire, I mean, I showed the slide, but on the resources page of the Spectrum Centre website, which is www.spectrumcentre.org, I think, you can download it, and you can also download the scoring key. I mean, I think a key issue is the thing that I was talking about one of those elements being about seeing recovery as a kind of lifelong process with fluctuations in it. So I think an important thing would be not to assume that, you know, say, you know, if you get a particular score and it changes, that may be just reflecting a fluctuation that's natural in one's life, rather than necessarily things getting worse or better. So actually, if one were to use this over time, it would be useful to do that, you know, on a reasonably regular basis for a reasonable length of time, to get a sense of a pattern, rather than just, you know, one or two data points. I think the other thing is, it would be surprising if sense of recovery, although it can fluctuate, it would be surprising if it changed radically from, you know, certainly from day to day and even from week to week. I would expect the time course of it for a lot of people to be a bit longer than that overall. So that would also be something to take into consideration, I suppose, in thinking about how often one would use it. I mean, the other thing that we've been doing in the UK to try and sort of get it out there, if you like, is we have been using the measure in the national demonstration site for bipolar disorder, which is run by the Department of Health as part of the Improving Access to Psychological Therapies initiative. So that means we're looking at recovery outcomes in the National Demonstration Site Service, which is actually based in Birmingham in the UK. But that means also that there's national guidance on how to measure this. So its accessibility, I think, will be improved by clinicians nationally being made very aware of what these tools are and how they can be used, so that they can also offer them, you know, directly to their clients and services.
Mm. And people can email you to have a look at a copy of it, Steven?
By all means, and so you can download it from our website as well, direct.
And did you want to share that website address?
Yeah, sorry, I thought I'd done that. It's www.spectrumcentre.org.
Great, just so people didn't catch it at the beginning of the presentation.
Yep.
So that was a wonderful webinar. Why don't you just end by looking to the future for us, Steven? You have these amazing initial results from Recovery Focus CBT. You know, if you could wave a magic wand, what would you like to do with this initial data, and where would you like to go over the next 5 years or so?
I think there's two ways I want to go, really, and I would like us to develop work in. I think one of those is looking at and understanding personal recovery itself better. So, I mean, we're really pleased with the Bipolar Recovery Questionnaire, and I think it fills a gap in the sort of in the tools that are out there at the moment. But I think there's still quite a lot we could still do to understand more about how personal recovery works, how it relates to other areas, and what it actually predicts. So there's a whole body of work in that area, I suppose. And that also relates to how delivery of care in general impacts on personal recovery. So, you know, I'm particularly interested in psychosocial therapies, but I think you can consider this sort of outcome in relation to all sorts of ways in which all sorts of services are delivered. And I think that's something I definitely want to get involved in. In terms of the trial data, I think we do want to scale up the work we've done and do something more definitive. The ambition would be to engage stakeholders very much in that process, so that were we to find in a large trial that this is as beneficial as it appears to be in our current work, that we can really embed it in practice. And I guess an advantage we have in the UK is with our National Health Service that if we can get compelling evidence, two things can happen. One is it can get directly recommended by the NICE guidelines, which are published by the National Institute for Clinical Health and Excellence, and are firm guidance for trusts on what they should be offering. And the other thing is, I think we need to engage with the people who actually purchase services as we go along. So clinical care commissioners, as they're called in the UK, are the people who hold the purse strings for what is and isn't, what is or isn't offered by trusts. And so I think convincing them through the cost-benefit analyses will be a big challenge. And I think that's part of a larger strategy, really, to try and get to a point where people with bipolar disorder are able to access a range of choices of support and therapy that can be actually matched to where they're at and the sorts of needs they have. You know, to move us a long way forward from where we were maybe in the late 90s, early 2000s, where, you know, people, even if they could access a psychological therapy, the only choice was one thing, and one hoped that that would work well for a whole range of people. Whereas I think we know much better now that clearly, you know, we need a wide range of things, from intensive face-to-face work to online support to apps and all sorts of things, to actually address people's needs as they're having them, rather than presume those needs without finding out what they are.
Yeah, so a palette of tools and resources that we can tailor and fit to where an individual person is at according to their priorities and concerns.
Exactly, yeah. Yeah.
That's a good place to end the webinar, I think, Stephen. I really want to thank you for joining us. It's a beautiful sunny morning here in Vancouver, but I believe it's a rainy, cold, early evening in the Lake District, or the edge of the Lake District where you're calling in from. So thank you for giving us some of your evening and sharing your exciting work with us. We'll look forward to having you back in due course to hear about next steps, and we will hope that the gods of funding and healthcare service delivery align with your vision for the next steps over the coming years too.
Yeah, well, thank you very much for the opportunity.
Thank you. Take care. Bye-bye, and thanks to everybody on the line for joining us, and we'll be in touch in due course about the next webinar we have set up in 2015. Happy New Year, everybody.
Bye.
Bye-bye.